So as we're running short on time, we'll quickly jump on to our next session before lunch. That is on other extracorporeal therapies. For moderating this session, I would like to invite on stage Dr. Gautam Aluwalia, Dr. Pramod Sood, and Dr. Sheetal Garg.
Arvind Daya will be speaking on VA key papers since 2017. Dr. Arvind is a director, Kellis Hospital and HOD Critical Care and Unit and ECMO Centers. So over to you, Dr. Arvind.
To pick only few papers in 15 minutes. There's a lot of happening in ECMO world. Many things are coming up, but and hardly any RCT on that. More of evidence in form of, I would say, retrospective trials, retrospective data, or systemic reviews. But I just tried to put all the data into two headings: validation of the previous work and all established indication, and the new frontiers. A little bit on that one. This is a slide from ELSO registry. VECMO very commonly used for all three age groups. Mortality ranging from 59 to 45%, going down as we go to the adult neonates. So in this one, again, I picked very selective three topics: MI and cardiogenic shock, and combined ECMO and Impella in cardiogenic shock. Most of the topics are already being discussed in detail, so just giving a flavor of it: levosimendan and ECMO. In acute MI and cardiogenic shock, as you know, it's a dreaded complication of MI. 5 to 10% of all cases develop it. In this one, ECMO case, ECMO use is rising now because the mortality is more or less same over last 2 decades. Hasn't been around 50%. Hardly any RCT. As you can see from ELSO registry again, use of ECMO in cardiac cases is going up and going up very sharply in last 10-12 years. And if you look at focus on the red line here, you can see that in the cardiogenic shock, the outcomes are slightly improving as well. Now, putting few systemic reviews in front of you all. In this systemic review, VECMO survival was around 41% in cardiogenic shock. Very low quality studies, but still some indication there. Next review, which was published in 2022 again recently, 16 studies included 11,162 patients, 50% mortality with VECMO in cardiogenic shock secondary to STEMI. In this review, they found that TIMI, body weight index, arrest to ECMO time, CPR, interval infarction, and age more than 65 are correlated with the outcomes. So, lactate was not very well correlated with the outcomes. So there's one small RCT I found. There's 21 patients in each arm, single center. The primary endpoint was LVEF at 30 days, and 30-day all-cause mortality was 19% in ECA this group, 33% in control group. So it looks quite a lot of difference, but it was not significantly significant. But there's a trend toward lower mortality. EF was same in the both the group at 30 days. So primary endpoint was not designed to check the mortality, needs a bigger RCT, and one RCT is underway at the moment in Europe. 428 patients to be enrolled, 39 centers, and endpoint is mortality. Now see, when this trial will be over, with more data on that one. Secondary endpoint in this one will be all-cause mortality at 12 months and more data on that. Let's see what EuroShock trial will show us in future. There's one more trial I found, 122 patients where in cardiogenic shock, immediate ECMO versus no immediate ECMO, but if ECMO was required in no immediate ECMO, ECMO was used in conventional group as well. 117 patient, 58, 59, both groups, 23% immediate ECMO later, 68 versus 70, 63 versus 71% mortality in the groups, equally not very significant. So we can say that immediate use of ECMO is not very superior. We can go for the convention to start with, and if not improving, then we can certainly think about ECMO in these patients. So again, the whole thing was that yes, we're using a lot of ECMO in cardiogenic shock secondary to MI, but timing in the case selection needs more improvement. Need to wait more for ECMO studies. Now the comparison of ECMO versus E-Capelline patient with this now a lot of interest in the Impella as well, and the combined form of ECMO and Impella. What's going to tell us about? So again, I have just pulled up two systemic reviews. In this one, 13 study, large number of patients, but ECMO had huge number with the ECMO plus Kepler. Mortality difference is there, which is significant in some. So we can say when we did look at the three studies directly, they found that E. Kepler was slightly superior and had lower rate of using heart transplant LVAD as compared to only ECMO. So whenever there is a need, ECMO is not helping, LV is getting dilated. If someone can afford it, yes, Impella has a role to play. That's what the initial trends are showing. Another study with the same number of patients on ECMO, not exactly the same, but not that difference as the last time. Again, here is showing the E. Kepler as a favorable in all the analysis. Levosimendan, again, very quick one slide. 7 studies, again, retrospective studies put for the systemic review and analysis. They found levosimendan does make some difference and help in ECMO weaning. So now, very quickly, I'm moving on to new frontiers, and in this one, mainly poisoning, specifically for Indian setup, where the wheat growing regions in north and some south regions, and countries like Iran, and some again a question of elderly and ECMO. And now the ECMO boundaries are being pushed for patients like trisomy 13 and 18, which I think will not be used in this kind of congenital disease. Okay, Dr. Vivek Gupta and our team from DMC, they have published this paper recently, 2019, which is the paper, second paper after first. This was the first paper, and the second they only recently published as well. This is the one paper which actually inspired me to start an ECMO program at my center. Before that, we were not doing ECMO. When I came to know the ECMO patients, these patients were universally fatal when myocardial set in. But now, with the help of ECMO, we are saving lots and lots of patients. This Dr. Vivek Gupta and a whole DMC study, we can say from here that survival was around 30 to 40% in the two studies, 33 in the 40% mortality, nearly 60 to 70% survival. And in the survivors, and the main difference was LVF on admission below 20 was the important difference. So again, a bit of a look on these numbers. So at Kainos, we are going to publish this study soon, a 3-year experience. We have done nearly now 70 to 80 ECMO for sulfos patients. So in this one, with only 1 year we have collated. Next 3 years we'll also collate it soon, we'll publish soon. Last year we did around 19 ECMO for sulfos, and around 21 no sulfos were not done. They were managed conservatively. So we can see that one, that major difference was low pH on arrival, low EVA around 20%, pH was very low in that sense, lactate was rising, a lot of arrhythmia in ECMO cases, high inotory requirement. We only lost 2 patients. So out of 19 we did, there's only 2 we lost. And no, overall out of 70, the survival rate is around 70 to 75% we are getting right now in sulfos. And if not a eCPR, survival on ECMO for sulfos is going in the range of 80 to 85% now at our center. So this is a high-risk group we found from our work and Dr. Vivek Gupta's work and DMC work as well. Arterial pH less than 1, lactate more than 10, systolic blood pressure despite inotropic support, LVF less than 13, more toward 25, very rapid deterioration and rhythm disturbances affecting the BP. In these cases, 70 to 80% chance these patients would need ECMO in next few hours. Age and ECMO, when I get trained in Leicester, at that time 65 was a cutoff. We were not using the Landgreen, largest center in the world. They were not using ECMO for more than 65, but now it's being used for 60s, 70s as well. But I think after 63, I'm not quoting all the studies, but I was putting a summary in one slide because of time constraint. Out of those 63 and there onward, there's a significant impact on outcomes of age, and 75 significant. After 70, survival rate goes down dramatically, and beyond 75, we need to think very, very cautiously. Age is no absolute contraindication, as I mentioned here, but the quality of life, comorbidities, 1 year survival should be considered before we put someone on ECMO. So it comes to my conclusion of my talk. ECMO is a very good therapy. If used judiciously, it can act as a tool which can help recovery of patient, and it can be a bridge to transplant or LVAD or transplantable LVAD. All it I'm saying is that now the biggest question which we need to face is the better selection of patient and better timing for using the therapy. Hope more and more such ECMO patient will be taken to decannulation and safely go home. Thank you.
Yeah, thank you, Dr. Daya. If there are any questions, I know pre-lunch sessions are like, the last period of the
Yeah,
schools when everybody is waiting when the bell will ring. So, ECMO obviously is an evolving thing just to, in a resource limited setting, cost obviously is a major question. So, as time will go by and more support will come from the government, this thing will evolve. You've done a good job.
Your experience with sulfose poisoning, like our mortality was around 36%. So what exactly in those 90 cases that you have gone?
so it's only 2%. We have two patients we lost out of 90.
Uh,
Yes. So,
and the timing of initiation of the ECMO.
so timing, we are lucky in that sense. We get very early. Now the center has gained a lot of traction that we are saving patients. So we are getting patients in first say 6 hours. Most of our patients come in first 6 hours. But what we are seeing that once they come early, their ECMO run is also shorter. Our ECMO runs in the range of normally 40 to 56 hours max, no, most of the time.
No, I'm sorry, in these 90 patients, you started ECMO.
19, sir.
19.
Yes,
So all of them were in shock.
severe shots. All of that, the average, I can show you the data on this one. This is, it's most of that ejection fraction on these ones are quite low. You can put up this.
Yeah, so
Below 30, sir. I mean, if I say that if ejection fraction is below 30, there's 70-80% chance the patient would go on ECMO. Many times we pull out patient out without ECMO when an EF is 25 as well. But when it's more in the range of 20, more below 20, and the anatropy is twice, then is a problem.
the advantage in poisoning is the body tends to clear it off. Actually.
Yeah.
That acts as an excellent
Exactly.
therapy as well.
Any questions?
Dr. Day, it's you rightly pointed out about the levosimendan, okay, during your investigation or whatever, weaning off. What did you have to give a bolus first and then go for a maintenance, or you just give the maintenance?
So to be honest, I don't have personal experience of it,
Okay.
and in sense, if you look at that, is not even available in our region now. So it's more of an academic exercise to put me out there. Whatever I'm gonna spell out of the books. But
Okay.
at the moment, I personally have no experience of it. What we use mainly is a dovitamin at our center.
Still,
So I mean, dovitamin in ECMO we use, especially
Yeah.
toward more weaning side when they are borderline weaners.
but don't you think that levosimendan has got an age? The maintenance dose of levosimendan has an age in this particular situation, in place of dovitamin.
So again, I say that unless until I
No,
use
your
that-
analysis, you must have
So
gone. through.
analysis, I mean, there's no comparison between levosimendan and dovitamin. Many a times we even fear the dovitamin should be used early or not. We start using dovitamin more after 24 to 46 hours rather than early, more toward the when they are just borderline. Just give it a bit of a push more than push. So I don't know.
I think levosimendan has a particular role, and if it is initiated early and in the appropriate manner, not even in this cardiogenic, but otherwise in the certain cardiac conditions, it has a
No, cardiac is fine, but I'm very specific about this
Because,
particular thing.
I don't think so. More and more studies will be coming on that would lead us to use of levosimendan for waiting for the ECMO patients.
I think it's
that is what the study was all about.
Thank you.
Yeah,
Sure.
okay, thank you.
Thank you.